Welcome, everyone. They're coming in slowly. I'm going to show a quick video.
Welcome to today's session, everyone.
We are PreMedCC, a student-led organization established in the fall of 2021.
Our goal as an organization was to create an online program for pre-medical students at community colleges and universities, with the hope of guiding the next generation of diverse and inclusive physicians.
And while we advertise our organization as being for community college students, our events are open to anyone.
We realize that finding guidance and mentorship in a pre-med journey can be especially challenging for first-generation pre-med students,
people that lack the financial resources, or just those who do not know people in the medical field.
One of the best parts about our events is that they are virtual, so you can do it from the comfort of your own home.
We typically have events on Fridays from 5 p.m. to 6:30 p.m. Pacific Standard Time, and on Saturdays from 11 a.m. to 12:30 Pacific Standard Time.
If you aren't able to attend the event, all of our sessions are uploaded on our YouTube channel.
Many of our sessions will end up with a Q&A with the speakers.
Any questions that you have, you may put it in the Q&A session on Zoom, and our team members will read them and have them answer.
After you have attended our event, you can log into our website and complete the quiz, which will contain questions pertaining to our session today.
If you score 70% or higher on the quiz, you will be awarded a certificate to show that you attended our session today.
If you want to stay connected with the upcoming events or just want to tell your pre-med friends about the PreMedCC, you can find us on Facebook, YouTube, Instagram, and TikTok as @PreMedCC.
Welcome to today's session, and today is an honor to welcome Dr. Spence. Dr. Spence graduated from Cal State Long Beach with a double major in biochemistry and chemistry and a minor in biology. Her medical training was completed at the University of California, Davis School of Medicine, and she received the Navy Health Professions Scholarship. At UC Davis School of Medicine, she developed a surgical program that aided individuals from underrepresented backgrounds to exposure to medicine and surgery. Upon graduation, she completed her surgical training in general surgery at Harbor UCLA, Torrance, California, caring for the underserved. Throughout her residency, she continued to excel, receiving Surgical Intern of the Year and Outstanding Service as Administrative Chief Resident. Currently, she is a Lieutenant Commander in the U.S. Navy. She has worked with the 1st Medical Battalion of the USMC and is now a surgeon for Fleet Surgical Team 3. She will soon become the Chief of Surgery at Camp Pendleton. Welcome, Dr. Spence.
Welcome. Thank you for having me. So I did have a whole presentation all for you guys, but unfortunately, my computer decided to revert back to whatever I was working on before, so it didn't save. So my apologies for that. So we're kind of doing a little bit more speaking to me instead of seeing all the cool photos that I had for you guys to look at. So yes, I graduated from high school in San Clemente High School. I actually focused on medicine and also danced. I then went to California State University and did my majors there. But in addition to those majors that I did, the other thing that I really liked doing that I urge everyone to get to be able to do is find a program that you can get yourself involved at a hospital to figure out what you want to do and where you want to do it. Just because you want to go into medicine doesn't mean that you have to be a doctor or anything else like that. There's nurses, there's other entities throughout there. You can do LVN, CVN. If you wanted to be an actual anesthesiologist, you can actually be a nurse that is called a nurse anesthetist and put them to sleep. So there's a lot of different paths depending on what you want to do, and not one is good for everybody. Okay. So the program that I did in Long Beach was called the Clinical Care Extender Program. It was a great program. It allowed me to get hands-on experience throughout every single department in the hospital. It allowed me to kind of shadow, do a little bit of work that was more of an LVN level. So you're not administering medicines or putting in IVs or anything, but you're working alongside the nurses to get that experience. And then it also gave me experience in the OR, where I got to basically shadow and watch the surgeons do their work. I also did some research in undergrad as well. I got involved at the local VA and did some awesome bench work for cancer research, which means that I basically worked with a lot of cells, pipetting them and it's making them resistant to different cancers, hopefully, by using them kind of like as a vaccine in a way and causing them to basically burst open and kill the cell that they are in. From there, I went to, UC Davis School of Medicine. That's where I met Jubin. And we did the pre-medical surgical internship program there. That program was a really great program, just kind of like a program like this. That one focused also on getting education of different surgical specialties for the undergrads. We actually got them college credit for it. Unfortunately, that program is no longer there because Jubin and I are not there and nobody wanted to take it on. It lived a short while after we were gone, a couple of years, but it just kind of fell to the wayside. But finding that doesn't mean all options are closed to people. Find people, you can always shadow them and get to be work with them one-on-one. There's ways to do that in the hospital, to have pre-med and even high school students to kind of get that opportunity to get a good way of exposure to medicine. Then from there, I did my residency at Harbor UCLA. Harbor UCLA is a level 1 trauma center in LA. It is kind of one of the major trauma centers in LA. So we took care of Compton, which is basically the gang and weapons area of LA. We also took care of anything from Catalina, anything from the LA Harbor, so crush injuries, other things like that. And then anything of what we say, fresh off the boat, but basically anything that came into the United States from people visiting from all over the world. So we got to see a lot of cool things that you wouldn't have seen unless you were in a third world country there, which was really awesome to get that exposure to. I basically did a whole lot of trauma in that residency. It was probably one of the best places I could have gone to give me great autonomy and a great foundation for surgery, and really kind of promote and excel my career as well. Fast forward to now, I've been with the Navy for about 3.5 years. So I joined them in medical school. I did the HPSV program. So what that program is, there's the HPSV program where you basically get to go into whatever medical school you got into and they pay for it. Or you can do their program and go to USIS, which is a medical school that is provided by the Uniformed Services. So that's kind of two options if you wanted to go into the military that way. So they paid for my medical school, and typically then you go do residency afterwards with them. My year, they had a really cool opportunity and had 1 or 2 positions that allowed us to do a civilian residency instead. So I went and did a civilian residency, and that's kind of how I got to do that instead of going through the military for that. If you actually went through the military and did your residency with the military, you get some cool opportunities in the Navy. After your first year, you have the opportunity to be what we call a GMO, a general medical officer, and they serve either with the Marines, since the Marines are a division of the Navy, or they serve on ships as their regular general doctor, or they also do flight doctors. Or the other cool thing with the Navy is it can be a dive officer, where you actually have to go to dive school and qualify for all the stuff that you would as a person who is diving. Then after that, you go back into your residency. There are some things in the military that you go straight through with your residency as well, instead of doing a general medical tour. And so those are opening up a little bit more than they used to be. From there, after your residency with them, you owe them however much time is dictated by what path you went. So for me, since I joined in medical school, I signed with them and they for a 4-year deal because they paid for 4 years of medical school. If I did my residency with them afterwards, then it would have, since I would have been paid by the military during my residency, I then would have owed them however long my residency was. So general surgery residency is anywhere from 5 to about 7 years. It's a really long time to go. And so if I did my residency with them, I would owe them at least 5 years at the end of it. For me, since I didn't accrue any extra time owed in the military because of my civilian residency. So I only owed them about 4 years, which is actually up this summer. But instead of getting out, I am staying in, and everybody's asking me, why am I staying in? What, am I crazy? Why would you do that to yourself? For me, there's a lot of different opportunities. There's things that I don't get to do as a civilian, but I do get to do as an actual Navy doctor. So the cool part about the Navy is I get to work with the Marines. So I get to learn all about field medicine, austere environments, basically putting everything on my back, hiking up a hill, popping up a surgical tent, and working from what we have. You're usually the only surgeon that is with the team. Sometimes with the 1st Medical Battalion, they do send up about 2 surgeons. But sometimes you could be with a different team that it's a more of a fast light unit team, and you may only be yourself. So it's really relying more on your knowledge base, your skills, and then just working with what you have, which is pretty cool. Beyond that, if I'm not with the Marines, I'm with the Navy. So I actually just was deployed for about 7 months this past year into the Pacific. So I was on.
Dr. Spence.
Yes.
Okay, your video just froze a second.
Oh.
It's working now.
Okay. So where did I leave off? Anybody? Okay. So I was recently deployed for 7 months out in the Pacific. I was on a ship that's basically, it's called an ARG. So it's the Amphibious Ready Group. I was on the largest ship, which was about 2,000 to 3,000 people that is on it that I'm in charge of. And then I'm also in charge of all of the other ships for anybody who needs any surgery. They'll get either flown over to my ship or I get flown over to their ship. We were in the Gulf of Oman while we pulled out of Afghanistan. Luckily, we didn't have to see anything that came to our way, but there's always the option or possibility that you never know what is going to happen. Again, working on the ship is kind of similar to working in the field. I have a lot more supplies per se, because it's not just whatever I can put on my pack or into our big, huge, what we call AMOLs, which are just canisters. We do have storage on the ship, but again, we're a little bit limited to what we have and what we can do. Then both of those ORs technically aren't as clean as if we were to go in a brick and mortar building, a regular hospital. On the ship is more clean than out in the field, obviously, but it still limits kind of what you can and can't do of what you want to do for any type of surgery that you have that comes across your way. You also are the most knowledgeable person in surgery in that kind of area. So there's a lot of different questions that you have to make that come along your way of what is right, what is wrong. We also do mass casualty drills every single month. So the whole ship is involved. Even the Marines that are embarked onto the ship are involved. And my job is to train then the other doctors that are with me, which is I have a general medical doctor that is just after their first year of residency. And then I also have on my team, an actual medical doctor, whether it's internal medicine or family medicine. So they've already been through their residency and trained. So there's not actually many doctors per se. There's also a senior medical for my team, the fleet surgical team, and a senior medical for the ship as well. But they're more in charge of figuring out kind of how that whole mass casualty goes. So what we use instead is our corpsmen. So our corpsmen are basically straight out of high school graduates. They come, they get special training at a thing called A school, and then they specialize from there to be either surgical techs. They also do radiology. So there's a lot of different variety for them. So basically they're like, we call them our mini doctors. They can't practice outside of the Navy per se, but they can do things that I wouldn't trust even an intern to do, meaning that they can put an emergency airway in called a crike. They can put in chest tubes. They can put in lines and everything. Some of them have even more skills than that, especially if they've been with the Marines before. So it's really cool. So for me, why I'm staying in the Navy is I get to work with a wide variety of people, not just my own specialty, not just people in medicine as well, because of when I'm on the ship, I work with a whole lot of other different entities that come into play with that. And I also get to learn how to be those type of officers as well. So this one is for going onto the ship and learning how to be an officer on the ship. And then that one is being a field medical officer as well. So it's these unique opportunities that you don't technically get in the civilian world. Yeah, I'm a little bit more where I could be leaving at a drop of a dime, depending on what platform I'm on. So I've been nothing but operational since I began. And so I had been kind of always said I could go in the next 24, 48 hours, which actually happened this past summer. I had to cover down for someone who got pregnant and had to be out in Okinawa in about 3 to 4 days. So that does kind of play a role and is a little bit harder on the family life and everything, but I still have a family. I have a awesome husband. I have 2 cats and a dog. We don't have any kids, but that's because I can't have kids. So, but I have lots of different Navy officers that are female that have 2, 3, 4 kids without any issues. I even have some of them that are both them and their spouse also military as well. So it's definitely doable if you want to have a family and everything else like that. So that's kind of why I'm staying in, just unique experiences. You get to actually practice around the world. There's hospitals in Italy, Spain, Germany, England. So there's a lot of different things you can do with it. We also do a lot of humanitarian work. So the Mercy is actually out right now doing humanitarian work where they pull into these places that have no surgical capabilities, but then they provide surgery to all of the people that are there. And these people will line up for like days and weeks in order to get their hernia repaired or other things repaired. We have our ENT people go out, so they do palate work or anything else like that. We have our gynecological people go out. So we have a lot of different specialties that go out on that kind of help with that humanitarian effort. And then obviously, as you guys have seen before, the hospital boats that go for any emergent reasons for when there's a natural disaster that you have seen before. So that's kind of it in a nutshell. Sorry I didn't have any cool pictures for you guys today to look at all of that. I was going to show you a little bit of the ship and some of the field, the pop-up oars and stuff like that, but maybe next time. So sorry about that. Do you guys have any questions for me?
Yeah, there is a couple of questions Veronica and Lily are going to ask you.
One of the questions that came up was they wanted to clarify if the Army pays for med school 4 years, you work for them for 4 years, correct?
Correct. So it's a 1-for-1 deal. Now, if you that changes based off of your specialty. So again, if you did medical school with them or not with them, but at a civilian hospital, if you went through USIS, it's a 1.5 years per year that they paid for, because you get paid differently when you go to USIS. But when you do it the civilian route through the HPSP program, it's a 1-for-1 year. As long as you don't as long as your residency isn't greater than 4 years, or if you do your residency outside of the military and you don't get paid by the military when you're doing your residency. Any other questions?
There is another question. Do you get where to pick, like if you were on land with the Marines or on a boat?
Do I get a pick? Yes, I do. Now, you don't always get a pick per se. They come up with a whole list of places that are available for when you are coming into active duty, of what positions they have open. Right now, they are trying to do fresh grads to not be on ships, not be with the Marines, and leave those to people who actually have more experience, and actually put them in a brick and mortar building like Naval Hospital Camp Pendleton, or the San Diego Balboa area, or there's a couple other ones elsewhere too. And so, but they do have a list of stuff, and then you give your rank of what you want, and they kind of match of what everybody's skills are, what other people want, and whether they have been in longer than you, and then that kind of shows what you get. But you don't have 100% say. Just if it's on your rank list, you could go to any of those, just kind of like as you do for a match system and going into residency.
We had a few questions for the HPSP program that came in. One of the first ones is, what is the difference between the HPSP and the Uniformed Services University of Health Sciences? What is your advice for someone whose goal is military medicine?
So the HPSP program is, you get to decide any medical school that you want to. You still have to apply to all those medical schools. You still have to get in, but the military will pay for that school and will pay a stipend for you to live off of. Now, it doesn't pay for every single thing that you want to live off of, but it does really help per se, where you don't have to take out really much or any loans per se. The USIS school is actually at the Uniformed Service School that's on the East Coast. You do all of your rotations and that through that school, and you get paid differently. So you kind of get paid as an officer, but because you get paid as an officer and you have to wear your uniform to work and everything else like that, then you owe more time. So instead of it being 1 for 1, it is 1 year for 1.5 years. So you actually owe more time then.
And just to kind of, oh, go ahead.
No, go ahead.
No.
And for what you want to do, which way you want to go, talk to each people who have been in each program and kind of decide what career path you want to go on, because it just depends on what you want. Usually most USIS school people go straight to a residency in the military, versus HPSP, they will have occasionally time where they don't go straight through. They get to do a civilian residency like me.
And we have the Dean of Admission from USHIT coming on May 12th, Captain Leota, who's going to do a whole talk about their program and what it takes to get in and all that good stuff.
Perfect. So you have another opportunity to kind of see what it is for that way. For how it works with the HPSP, how you get in is, again, you apply to whatever medical school you want. You get into that medical school, and at the same time, you talk to the Navy. You then decide which branch you want. Do you want Navy? Do you want Army? Do you want Air Force? And you work your package through one of those branches, and you then get accepted through them, and then they pay your school directly, and then they pay you directly for other things as well. So that's kind of how it works. You have some interviews that go along with it. It's a big, huge, long application, as anything in the military is always a longer procedure to do. You can do it anytime in your medical school career. I did it after I got initiated into or sworn into the Navy after my first year of medical school. I was working on it kind of in the first year because I wasn't 100% positive based off of what my family wanted me to do. So I kind of was showing them that I wasn't doing it for just the money. Definitely don't do the military for just a free ride. There are plenty of other ways to get your medical school paid for. There's loan forgiveness programs if you want to work in underserved areas. So let's say I didn't do the HPSP program. My residency, because it was an underserved area, was 6 years that I paid back my loans. All I had to do was another under area service for 4 years and everything would have been paid for. So don't just do it because of that. It is a career. It's a lifestyle. It's definitely different than the civilian world per se. But there's a lot of honor and privilege and just a different sense of being in the military than in the civilian sector. What else? Any other questions, Jubin?
Veronica, do you want to?
Yeah, kind of following up with that same theme of HPSP. How does an individual get into HPSP? I tried going to a recruiter and they tried super hard to recruit me as an enlistman.
So there's an actual, you go to a recruiter as well, but it's a medical recruiter that you go to, and they will, it's a whole different application that you fill out. They look at your MCAT scores, your actual score that your GPA and everything. They look at your personal statement, just like they do for going into medical school. And from there, then your whole application packet goes through the military and then it gets approved or not approved with that way. So usually if you just go to any recruiter, that's the best way of going. HPSP, you want to have all the prerequisites. So you want to have your undergrad done and or about ready to be finished. And then you're going to then be applying to medical school for that. And then at the same time, or even right after you got into medical school, put in that packet in through the military. And I believe Jubin just shared kind of a little bit more for the HPSP program online for you guys.
There is another question about what is your specialty?
My specialty is general surgery with more of a trauma emphasis, meaning that where I did my residency, I did a lot of trauma. So I'm very, very comfortable in trauma, and all in military, all of us are kind of trained a little bit more in trauma per se too. I'm actually going to go do a specialty of trauma critical care here in the next year and a half. And that's also going to be through the military as well. It will be at a civilian residency or civilian training for that, but it will be paid through by the military. And yes, that does mean I accrue extra time for them.
Another question that came up was, being a doctor in civilian and military world, do they pay the same? I mean, as the salary?
They do not pay the same. They pay differently. You don't get any bonuses per se when you're paying back the years that they paid for medical school. But after that, you can do signing bonuses, and depending on what your specialty is, depends on what signing bonus you got. So they're really more looking for wartime critical specialties. So those ones pay a little bit more comparable to the civilian sector. There are obviously tax breaks that you get as being in the military that you don't get. So all in all, for me as a surgeon, it kind of, yes, I would get paid more if I worked in the civilian sector, but I probably would work a lot more than I do and be on call a lot more of the weekends than I am now. Or even have the potential even making a lot more money. but they, as soon as I signed my 6-year retention bonus, it makes a little bit more comparison where you kind of have to weigh what you want in your career.
You also don't have to pay for you also don't have to pay for your malpractice insurance or any
Correct.
other costs.
Yeah. So there's, you know, and also like if I need medical care, I have no copays. I don't have to pay any copays for any of my medicines that I take. So, you know, there's other pluses and minuses to everything to it. But the military does really kind of dictate where and what you do. And just so you have to be ready for that. Do I wear this uniform every day? No, because I'm a surgeon, so I get to wear my scrubs. But if I get sent out in the next 24 hours, then I pack my bags, I get sent out in the next 24 hours. I don't really have much of a say of saying no to it per se. There's some things, obviously, if you have family things going on or you have other entities in your life, they do take those into account, and that's hence why I've had to cover down for other people. And you're not always one of one, which means right now I'm in a division where I'm the only surgeon. So I'm the only one that has my specialty, versus when I was with the Marines, there was about like 8-9 other surgeons that was with me. So someone else could cover down for me. When you're in the hospital, there's kind of a little different, more coverage with that. So it kind of just depends on how everything goes, but it's not like, for instance, this weekend we have what we call 96-hour off. So if I'm not on call, and I have no duties that are with my fleet surgical team, which I don't, I have the next 96 hours off, which means that I don't report to work or do anything like that, but I have to stay within a certain mile radius. Otherwise, I have to take leave. So there's other perks that you get days off that you are not working, but you're still getting paid. It doesn't change your salary, anything else like that. So there's pluses and minuses to everything. But yes, not having to pay for malpractice, not having to worry about that sort of stuff is quite different. Now you can also moonlight in the military. So what that means is if I wanted to on my own time, either take leave or on the weekends when I'm not working and not assigned to anything, I can work at other civilian hospitals around here and get paid by them. Caveat to that is if any military personnel comes in, obviously I can't provide care for them. Another person has to step in to do that so that the hospital can get paid for it through the military, because otherwise it's called double dipping. And then I also have to have my own malpractice insurance, or the group that I'm working for has to cover me for malpractice.
There's another question. If the Army or like the Navy pays for med school, the 4 years, do you work with them the 4?
So an HPSV program, you don't do anything with the military until you're done, except for you go to officer school. And typically you do that in one of the summers in your medical school, typically in the first summer, because you have that break there. Now, it's not always done that way. For me, they actually didn't have me go to officer school until I actually was done with residency, just because of how everything kind of worked out and what was available and that. If you do USIS, yes, you do a lot more stuff with the military, but which means that you are doing your weigh-ins, you're doing your workouts with them and doing other things, but you're not doing like that month of time period that you hear about reserves that you have to go every month or to do, and that it's not that per se. So same like when I was in my residency, I had nothing to do for them whatsoever, except for send them things from my residency saying what I'm doing, how everything is going and that, but I didn't actually report anywhere or do anything until I became active duty.
Like if you're going to graduate, if that kind of stuff.
Correct.
And another question that came up was if there's an cutoff age or age cutoff for HPSP or for the straight to residency program?
There is a age cutoff. I'm not sure of it off the top of my head, but I do know there is an age cutoff because just like even if you were already a doctor getting into the military, there's age cutoffs for that as well, because they need to make sure that they have enough healthy people in a certain age group in order to do the activities that we do. But I'm pretty sure that website tells you everything that you need to know, the nitty-gritty of how you can apply, what is the age cutoffs for everything, what type of scores they're looking for, and that. And then as far as which branch you want, it really kind of just depends on what you like. I chose the Navy because I also get to work with the Marines, but some people like the Air Force better. Some people like the Army better. For me also, I took into consideration of where all the bases were, and I kind of like land. I like sea and mountains, and not really inland in the middle of North Dakota or other things. So that's maybe also why I chose the Navy.
Another question that came in was, are you aware of the process to get assigned to a special operations command as a doctor?
You mean once you are already a doctor to getting a special operational command, or once you're in the military to get it? I'm guessing once you're in the military to get it. It's really just talking to the specialty leaders and seeing those for all of the secret scroll stuff that the doctors do. There's a whole process that goes through that in order to be able to do that. But yes, there are teams that do more secret scroll surgery stuff, which means that they go with those special teams and are their medical team for that team, and are very, very kind of more privileged in a different way, but have a lot of different clearances to get that. So I don't know off the top of my head of how all of that happens, but you got to be in for a while before they give you those positions.
I guess they want to know if you could become a Navy SEAL as a physician.
Oh, typically no. Typically, you can't be a Navy SEAL or anything else like that. It's two separate things. Now, you could be a Navy SEAL before being a doctor. There has been people who have done that before. We have people become astronauts before. I believe there's a guy who was a Navy SEAL, an astronaut, and then went to medical school, and that through the military. So there are those opportunities. If you want to do more of being a flight surgeon or a dive officer on that, then doing your being more of a general medical officer or family med, internal med, and stuff like that, because those positions are usually typically filled by them after your residency. As a surgeon, I don't get the opportunity to go do those things because I'm highly specialized and needed for wartime critical things. And they already have, our numbers keep dwindling for that. And so they don't want us to go be a deep sea dive officer for 2-3 years and not keep our skills up or be able to be deployed as a surgeon.
Thank you. The next question is, will I be eligible for TRICARE and BAH like regular military officers?
Yes, so you get your, you have TRICARE, your family has TRICARE and has all the coverage for that as well. And then you have your BAH depending on how many dependents you have, and it's based off as an officer level as well. And that is also different tax bracket and stuff depending on how much it is.
What does your day look like a typical day in your life?
A typical day in my life now, because I'm not a part of the hospital, I have a little bit more leeway. I am also the person that does a lot more than the normal. So most people, if they were in my position, they go to the hospital for their clinic one time a week, and then they do their operations the other time a week, and then they have for their own command, so fleet surgical team, then I have one day that I'm doing stuff with them. So that leaves 2 other days for the 5-day week to kind of do other things, whether that is moonlighting and working at their hospitals, or working back at a military hospital. For me, I actually, since I was with the Marines beforehand and now with the Fleet Surgical Team, I've worked at Camp Pendleton to keep up my clinical skills for ever since I came in. So I have my, again, still one day of clinic. So clinic starts at 8 and I'm done at about 3:34. And then my OR day, I start at 07:30 and I'm done at about 1600, depending on how many cases I have. And then once or twice a month, I also do endoscopy. So I do colonoscopies and looking also for upper endoscopies, EGDs. And again, that's kind of about the same time periods. In the military also, in order to promote, in order to get the leadership positions, you have to be involved in the hospital. So I actually hold down 3 different positions in the hospital right now. I'm the medical executive chair for the Surgical Quality Care Committee that looks at NISQIP data. And then the Operational Interventional Procedures Committee that looks at all people who do different operations or procedures in the hospital and whether their outcomes and how to better improve everything. And then I'm also head of the GME site coordinator for general surgery. We don't have our own residents. We get our residents from Balboa. So the Balboa residents rotate with us. So I help facilitate that. And then also we have family medicine residents that are part of Camp Pendleton Hospital that also rotate with us, and I provide them education and training in that. And then come this summer, as Jubin says, I'm going to be made a department head for the general surgery department of Camp Pendleton as well. So hopefully I'll get some of those other things that I have off and hand them down to other people that I'm involved. So for me, I work a lot more than some of my counterparts, but it also helps to get different things. So for me, I applied this year for a fellowship for trauma critical care, which actually in the military is one of the most competitive specialties to get into. And it usually you have to apply about 3 to 4 times before you get it. I got it on my first try because I've been nothing but operational and gone on deployments. And then also because I've been very heavily involved in the leadership roles as well.
Yeah, so I know her personally, and she's a very hyper person, so she does more than she has to. I think anything in life is either it's the military, either it's civilian, either whatever. If you want to get involved, you can do it. But it's just that you want to do it, and nobody's going to push you to do it. And one of the other things is once you are in any organization, military and non-military, if you have advanced training and degrees, not a lot of people are going to stop you from doing what you want to do. So take that with a caveat of if you want to, I don't know, join the military and I don't know, want to do surgery underground or something, I'm sure there's some sort of program or training that is available for you, or you could just go do it and there would be support for it. So one of the questions that's come up, and I'm going to put that in the chat as well, but can you explain what medical underserved area is and how you don't need to go to a developing country to do that?
Yeah, so a medical underserved can be any place that just doesn't have surgery or medicine to it. So there are places actually in the continental United States that there's a wide disparity of healthcare to them, meaning that they have to drive hours upon hours to go get and receive healthcare. Or it's just that they don't have to drive very far, but the people that you serve are underrepresented, underprivileged, or just those areas. So for instance, Compton is an area that is basically an underserved area. And so working at Harbor UCLA, since it serves that community, then is an underrepresented, underserved area. And so that's the other way of doing it if you didn't want to join the military, but you wanted to still get your loan forgiveness is what they call it. So you're still paying off in doing your loans and everything for 10 years. So it's not that it's completely scot-free for that, but then they kind of forgive those loans at the end of 10 years. You have to prove everything of all the areas that you worked at, but once you prove it, then it kind of gets all written off for that. So there are areas in major cities, and then there are areas in like places like North Dakota, Utah, and other areas that just there isn't as much medical personnel there.
Yeah, and you don't need to really, like, medical underserved area in the US, you don't need to go that far. I mean, if you live in Beverly Hills, Harbor UCLA is like 18 miles from Beverly Hills. Beverly Hills, you basically could go 6 miles and you're in a very medical underserved area and poverty. So people always say, oh, well, I need to go. It's like, no, not really. You could literally go 3 miles from your house and you could hit a place that's medically underserved area. And so obviously the military has certain things that, I mean, they're deployed in very rough areas. And so that's available. That's out there as well. So, and I'm trying to put this thing in there, but somehow the chat's not working. So I apologize. I have this whole thing that I was going to put into the chat, but my chat is not working. I don't know why.
You handle a lot of trauma cases during residency. Do you ever just get like really stressed out when you handle a new one, or did you get used to seeing those kind of cases come through a lot?
You got used to
I could
seeing them.
answer this. Knowing her, she probably runs to it, but that's just.
He is right. I was so my other counterparts, if you don't like trauma, you at my residency, you would definitely figure out whether you do or do not like trauma. But Jubin is right. I'm the one who runs to it. For instance, in my last year, so after 6 years, my last rotation that was at my institution, I was on call on my birthday, and call is every 3 days, 30-hour shifts or 24-hour shifts. But you have the next 6 hours to kind of clean up your stuff and go. So for me, nope, I run to it. I love it. It's like an adrenaline thing for me. Maybe that's why I'm in the military. But it's also what I love is there's no time to plan. You have to figure out what's wrong with the person, how to save that person, and how to fix it. And it doesn't mean that I don't like the planned surgeries. Like the big, huge oncological cases are really awesome because, again, not every one of them is the same. But for me, I like to operate everywhere and anywhere. And that's kind of also different in the military. For when we are deployed, we're trained to do basic ortho procedures, deliveries, basic gynecological procedures, urological procedures, vascular procedures, endoscopy. So we are a true general surgeon, where you don't get that in every single civilian hospital. Now you can get it. There are lots of places that you are the only specialty of surgery and that you get to do a lot of different things. But not always at different trauma centers. So like my trauma center, we did our own vascular work, but if the bladder was injured and stuff like that, if it needed a bigger repair than just a small little thing, then we would call in the urologist. If there was an orthopedic injury of long bone injury that needed a external fixation to it, the orthopedic surgeons would do it. When I'm deployed, I'm the one who has to do it because there's only me. So that's also the uniqueness about it is I like being able to know a lot of different things. And I also like trauma critical care because in critical care, you have to know all of the medicine, and it's a little bit different in a trauma setting of medicine than in a regular setting. because the body reacts differently. But you still also have to know every single thing that happens in the medicine critical care as well, because you get a whole bunch of different ages of people and different medications that they're on, end-stage liver disease, and they happen to have a trauma. So there's a wide breadth of it that you have to know, and that's kind of why I love it. But you can get very, very burned out for some people, especially seeing same patients over and over again. I had one patient that came in my first year of residency, and I operated on him 3 or 4 times. Now, not one was just due to gang violence. The rest of it wasn't from me. But then again, he was out of the game, and then he got shot again the year after my residency, and then several years after that, and unfortunately has passed away. But I had that whole relationship with him and his family because I took care of him for so long. And there's different opportunities that you try. At least in my residency, we had a trauma survivorship day where actual trauma survivors came, and we honored them and honored their families. And then we also did programs to try to help them get out of situations that put them in more high risk of having a trauma happen.
How would you define a leader?
That's a tough one. A leader is somebody, to me, who basically somebody can look up to, somebody that has a good moral compass, knowing right from wrong, and in medicine does what is right for the patient. For me, as long as you do everything that is good for the patient and you treat them basically like they are how your family would want to be treated, to me, that is kind of what I look for in a person. But being able to basically be that person where all kind of specialties can look up to and honor and show that you have the best interests in that patient's welfare. At least that's a leader to me in medicine. Everybody is different in which way they go for leadership. But definitely having a good moral compass is one of them, and doing what is absolutely right. Not just what is easy.
It's going towards leadership and that theme. Have you experienced any type of issues since you hold these leadership positions in the Navy, the military, and with your job there?
Yeah, so there are people who just don't do maybe what is right, or maybe they didn't learn how to do different things. So yeah, you do get to have those awkward conversations of, no, you don't get to leave when you're on call and you're at the hospital just because there's no patients. Like, you have to stay for, or depending whatever the hospital rules are. Now, yes, there are places that you get to take home call and do all of that sort of stuff for, but yeah, you gotta be that person to hold people accountable for it, because the more that people can get away with, even with doctors, the more likely they're just gonna go do, and because they can. So, they don't have to show up because they already did their other job and people are thinking that they're gonna be in another place. So that's kind of the more difficult part in the military, is you're owned by your company that you work for. And if it's not at the hospital, then you also owe the hospital stuff too. So that makes it kind of complicated, of the hierarchy, and holding people accountable and just going through the right steps in order to get that done for it. And it still is the same, like when you have patients being held accountable too for whatever stuff that they need to have done as well. So it's just kind of learning the language, and then also learning the hierarchy of how to make people responsible and dedicated to what they do.
Oh, sorry, you can go on, Didi.
Okay. Do you work the same hours as a civilian doctor, or is it different, like the military and the
It's typically different. I probably work a little bit less per se, meaning I'm done with stuff at the hospital when I'm done with my work. I don't have as much call per se, and it really just depends on where you work too. So for my counterparts that are my kind of same year and everything else like that, I'm at the hospital a lot less, but that's also because I don't have either as many cases or as many people in clinic and stuff like that. Yeah, we are all about getting as much numbers as we can and everything, but we don't have, a lot of the big companies, Kaiser and any hospital, they get paid off of how many people they serve and how many people are in clinic and how many people you operate on. It's not the same in the military. So I do have a little bit more time with patients to care for patients, and sometimes just as much as in my clinic as I would in a civilian world. And then other days, not as much, because again, it just depends on what kind of fluxes into the clinic. And also depends on how many surgeons we have at that hospital. So if it's lots of people are deployed, then I'm a lot more busy. I get to see a lot more patients. If I don't have as many deployed, then we spread the wealth for what we do. But if you ask overall, I probably work when I'm not deployed and not having to work weekends for other different things besides being on call. I work less.
Another question that came in was, have you been deployed for military humanitarian efforts in the Middle East before?
No. So my deployment, that was 7 months, that was specifically for withdrawal of the military from Afghanistan. So I didn't do any of the humanitarian efforts that they are doing. The hospital boats typically pull from the people who are stationed at the hospital. And since I haven't been stationed at the hospital, that's why I haven't gotten to do that. My counterparts were on their mercy, since we're on this side of the country, for when their COVID happened. They did send a surgeon there, but then promptly sent them back because they realized they didn't need a surgeon per se. I have some other friends that are out now being in Sri Lanka, helping with humanitarian efforts and providing services.
Another question that came in was, do you personally speak any languages other than English?
I used to speak French and I used to speak German, but that was a long, long time ago. So I'm not fluent in either one of them. Occasionally I can speak a little Spanish, but then when I speak Spanish, my French all of a sudden kicks in, and then it doesn't end up well. So no, I don't, unfortunately.
One of the questions that came up was, when you guys have to set up the tent and you have the canister, do you have everything you need, or do you get help? You do have everything?
Yeah, so you have so every single group or platform has a thing called AMALs, which are basically everything that platform needs for their deployment is in this AMAL. So it has the tents, it has all the medical supplies, it has the ventilation, my surgical supplies to it, if that is what that AMAL is set for. And it is the role of the people who are involved in that deployment to make sure that they have everything that is supposed to be in there. So you kind of run through everything, look at everything. For the Marines, it's all kind of prepackaged in this big, huge canisters and can be very easily transported. I did develop for the Marines a more lighter, quick surgical service team that was a team of 10 that could fit on an Osprey. And we had like only 10 of those canisters to be able to pop up and accept 2 trauma patients at a time. So there are some development into those as well. Especially the ship is slightly different of what is on there because of different capabilities that a ship can do instead. The ship that I was on had the ability to go up to 6 ORs. Now, only 2 of them were working ORs while we were deployed, but we do have a total of 6 ORs on that ship.
We were also wondering, what did you do for self-care during your residency and kind of seeing all those cases coming through the hospital? How did you take care of yourself?
I did yoga. I worked out. My husband, that's what I was going to show you guys too. My husband and I like to travel and go to lovely tropical places. So whenever I could, I would take time and travel and be with my husband. I would make an effort to, when I was post-call and wasn't tired, to meet up with some friends and have a lunch or a breakfast and hang out with them beforehand. I love to bake and cook. So I actually, every time I was on call for my 24-hour shift, I would actually bake something or cook something for the team. So that way we had like a little cool treat anytime we wanted during our shift for that. But it's really finding whatever you want. So if that means you want to go for a long bike ride or a long run, or you want to go meditate and cuddle up with your animals or be with your kids, that's what you do. It's just finding the time and, making sure you are studying as well for it, because you do have to take exams still in residency. In surgery, you take a yearly exam, and then you also have what we call mock orals. Because at the end of your residency for surgery, you have a big, huge multiple test that you take. That's like an 8-hour long test. And then you have oral boards still as well. But you can't make through anything without decompressing.
The next question, how does American and Russian relations look for the next 10 to 20 years? And what does it mean to be a military doctor?
Well, I can't really talk about some of those things. So whatever is in the news is what you guys get to know.
In the military, it's called being above your pay grade, and that's
exactly
above your pay grade.
Yep. So there's a lot of things that I don't even know as well, per se.
But in reality, if the military is deployed somewhere, they need surgeons and doctors and everybody else. So
correct. So that's why, for me, or for the military, I've gotten all that training that they want. I know how to operate and take care of people on ships. I know how to do that because I helped train the nurses to do it on the flights. And I'm not a flight doctor, but I have helped them do that training when I was with the Marines. And then I know how to set up a tent, be dropped off and set up stuff and provide care. So there's a wide variety of different things of how they provide care. It's not always in a regular brick and mortar building for even surgery.
Like another question that I was wondering, do you have time to care for your pets during residency, or did your spouse help? Or
no, I had time to care for my pets. We had 2 cats and a dog at that time, and I would feed them in the morning and take care of them at night. Whenever I was on my 24-hour shift, my husband wasn't there. Typically I would have someone come, take care of the dog and walk the dog or something else like that. I also had, I got eventually an automatic pet feeder and automatic litter box just to make my life a lot easier. Plus my house doesn't then smell like litter. But you can definitely have pets in residency, and most of us did have pets. Cats are probably a little bit easier than dogs because all they need is a litter box, some food and water, so you can kind of leave them alone for 24 hours per se. A dog's a little bit more work.
Can you tell them what was your schedule like in residency?
A lot more busy. So it depended on what rotation I was on. Again, if I was on trauma for when I was a resident there, we were Q3 call. meaning that I was on call one day for 24 hours, then I went home and slept. And then the next day, if it wasn't my day off, then I would come in for about 4 to 6 hours, basically however long it took me to do all the work that I need to do and do any like simple cases that we had scheduled for the day. And then the very next day I would be on call again. They've changed that now to because they have 4 teams instead of 3. So it's now every 4 days instead. So it gives you a little bit more time. When I was not on those rotations, I would get there at about 6:30, depending on how many patients I had. For my residency, especially in trauma, sometimes I would have 30 patients on my floor that I had to take care of. For some of the other specialties, I would have anywhere from 2 to 15 to 20, depending on how busy, what time of year it was in that. And so typically on most services, you have clinic once a week that you go to. Some days it's a full day clinic. Sometimes it's 2 half days of clinic. But you are there until you're done seeing patients. Some of our clinics had 100 people in a half day that we had to see and divide between 3 or 4 of us. So every residency program is different on how much autonomy you have, what are your hours like, and everything else like that, especially even if it's surgery residency. But typically I would go home per se anywhere at usually about 6 p.m., sometimes later than that. And it was just, if we had a long case, we had a long case. There was one day that I was on surgical oncology. We started a case at 7 o'clock. We got done at 2 or 3 o'clock in the morning. I went home, went to bed, woke back up, was back at the hospital at 6 a.m. You do have sleep call rooms at the hospitals as well to be provided for. And typically you have, any residency gives you 1 day off a week, or it averages to be 1 day off a week or 4 days off basically in a 4-week time period. You do have restriction of hours. You aren't supposed to work over your 80-hour work week. That doesn't mean, again, that's an average. So over those 4 weeks, it's an average of 80 hours. So you could do one that is like 120 hours and then the next one being like more 60, 70 hours, but it just has to average out to be 80 hours a week. And that's if you are actually putting in your hours and your program actually cares about your hours. So you're definitely super, super, super busy. And then you got to find time to study as well, because you have to know, at least for surgery, you have to know all about your cases, all about the imaging, the pathology, everything else like that, especially if it's oncology cases that you were doing. Sometimes for trauma, we read our own CT scans because we would read them by ourselves because it took about 12, 24 hours before you actually got a read for them. Or could go back and look at them. So there's a lot of stuff that you are doing, and it just busy. But surprisingly, I still miss it.
Okay, we have another question. How was your experience in med school? Was the competition extremely fierce in med school? I read a student try to sabotage another student that almost put a patient's health in jeopardy. Did you experience any of that in medical school?
I didn't experience anything like that. Now, yeah, there was, just like any school, there's cliques and groups and stuff like that per se. There are some people that, want to take kind of ownership of what you did in a way. But overall, no. And especially a lot of the schools are going to just a pass-fail system. Even the boards are going to a pass-fail system. So all of that stuff is kind of going away for the most part.
Well, and I could tell you that if you're a student and you see somebody sabotage something and puts patients, you're actually obligated to report it. So,
correct.
And plus, as a medical student, there's a lot of eyes on you when you're inside the hospital. So for a medical student to do that would be really, really hard. But if you see somebody doing that, you're obligated legally to report it. And and if you don't, then and if because it things are found out pretty easily, and so then you could be in jeopardy as well. But I've personally worked in teaching hospitals for years and never seen anything like that, because medical students can't do anything that there's residents, there's fellows, there's attendings. So that's just, pardon my French, crap that people read on, you know, posted or social media or Reddit or whatever. But it's that's far from truth.
Yeah. There was nobody destroying other people's notes or hiding people's notes or doing anything else like that. And everything at the hospital is regulated. So as a medical student, you can put in orders, but it has to be co-signed by your resident. And then not only that, but then any pharmacy orders go through pharmacy, and then pharmacy verifies whether it's good or not. And then the nurses get to it, and then they decide whether, if they have any problems with it. If they have problems with the dosage, or if this medication is not right for that patient, then they speak up. So again, yeah, you don't see any of that.
Was there a rotation that you did in medical school that kind of solidified that you were not going to want to do a specialty that was out there?
Family medicine and OBGYN, just not my areas of stuff that I like. Emergency medicine I did like, but I didn't like that I would just hand off the patient once I kind of stabilized them. And then radiology was great and cool, but I can't be in a dark room. I would be like 500 pounds eating to stay awake. But it was a great rotation to go through, because now I'm able to look at images and read them myself. Now, granted, I'm not like dictating them or doing anything like that, but I can understand what I'm looking at, and then I can even sometimes find things that radiology miss.
Is it competitive to get into military medicine?
It just depends on the time. Sometimes it's really competitive, and sometimes it is not. Just like anything, it just depends on supply and demand. So same like medical school, if there's a lot of medical schools and not as many people applying to medical school, well, it's easier to get. If there is not as many medical schools, a lot of people are applying, then it's harder to get in. But they do have different MCAT scores that they if you get below that, they don't really look at you either. And it's the same, like it all depends on, again, how well are you going to be successful in medical school. The MCAT kind of does go along with how well your knowledge base is and how much you can learn. That doesn't mean you just get one score and you're done either, right? You can get, you can keep trying and keep trying. And just because one door is closed doesn't mean another door isn't open to you. There's different ways to study and improve test scores as well. So it's not just that, that's it, you can't get that MCAT score. For me personally, I actually had my MCAT was fine, but when I was in medical school, the STEPS scores, so my step 1 score, I barely passed and was in the bottom like 2%. And I had a lot of other personal things that were going on during that time period. But I also was diagnosed with ADHD as well. I was placed on medication, but then I came off the medication because I didn't like it, and did my second test for medicine and scored in the top like 2%. So, just the test taking does not mean that you know the knowledge or not. It's a different way of doing it, of testing. And so you got to learn the tricks and the trade in order to figure out how to do that well on those tests and how to make them easier for you. So yes, there's a base of knowledge that you have to know, but just because you don't do well on a test does not mean that you don't know the knowledge base. And just because you do really, really well doesn't mean that you're also going to be a good doctor either. I've seen those people too who score at the very, very high end, and then you get them in the real life world and you're like, not so sure if you really understood that. So and that's kind of why they're going to more pass-fail system with the testing, is because it doesn't dictate how well of a doctor you're going to be per se. It's just the hoops that you got to jump through.
And there is like a prerequisite to get into the Navy, to be a Navy doctor.
Same prerequisites as what you need to get into medical school. Yeah. But you don't have to do a science major or anything else like that. A lot of times people are getting more successful by being English majors and just doing all the other prerequisites or other majors that aren't science for that. So it's not, you have to do this major or anything else like that. You just have to do the prerequisites. Pick a major that you like and want to do, because then you'll excel in it, and then do all the prerequisites. If that happens to be a science major, great, go for it. If it doesn't, that's okay too.
Could you have like a mentor if you're doing military medicine, since you're usually the one that knows more than everyone else? Like, could you have a mentor, or do you are you the one mentoring like others, or how does that work?
So I mentor those that are below me per se, but yes, I do have a mentor. I have people above me that either are in my command or not in my command, but have been in the military or in surgery for a long period of time. You also have what you call your specialty leaders as well, that help kind of guide you and do that as well. So there's definitely people that you're not just thrown out there and swim or fail.
Anybody else with any other questions? Because if not, we're going to let Dr. Spence go, because it is her weekend and I'm sure she wants to go do something fun.
My husband would appreciate me doing some fun things. He's also off this weekend. But I'm happy to take any more questions if anybody has any further questions. And if you don't want to, have those questions, Jubin can give you guys my information, and you can always reach out for me that way. I have mentored lots of different residents or medical students, or even high school people getting into the medicine, and I'm more than willing to help and look over things and do whatever people want.
Hey, do you want me to share this email?
Yeah, you can share that one.
All right, well, here's her email if anybody wants to reach out to her. I'm putting it in the chat and you guys could all see.
And there's no stupid questions. There's only things that you don't understand or haven't figured out yet. So, and even if I may not know it, I can try to put you in contact with other people that probably know it, or different specialties if you're looking to talk to other people.
All righty. Well, I think we're going to let you go a little bit.